So, hello again. I'm Barbara Janíková, and I will host this webinar today. And this is webinar focused on best practices in infection disease testing and treatment. And it's hosted within the BOOST project, which is the European project focused on HIV, HCV, and other infection disease prevention. And the main aim is to enhance the implementation of high-quality community-based communicable diseases services as a part of comprehensive, people-centered, and integrated harm reduction approach. And there are several work packages within this European project. And today here we are with the colleagues from work package 4, which is called support. And within this work package, we try to enhance and scale up the integrated community-based good practices. And we will be today presenting the best practices of our workplaces within 4 countries. And next week, 27th of November, we will share the practice of linkage to care. And we are also inviting one organization each to cooperate and to introduce our work, our shared work between the organization participated in this project and one organization we are working with to help them enhance their services. So within the today webinar, there are 4 speakers from 4 countries, and I would like to first introduce Tessa Hendricks from Belgium. Tessa is coordinating health promotion in injecting drug use at NGO Free Clinic in Antwerp, including the needle exchange and Hep C programs for people who inject drugs. And she's educating and building new projects, advocating for better access and care in HCV care cascade. She has worked for more than 25 years in the harm reduction field and founded the C-Body project that she will be speaking about now. And also I would like to welcome Stefan Bratnov, who is a peer worker in Free Clinic, and they both, Stefan and Tessa, will introduce their project. So I would like to give a floor to Tessa and Stefan, please. Thank you.
Try to share. Is it working?
It's
working. Yeah.
Okay, perfect. So welcome everybody. I'm Tessa, and I will present shortly the work we did in the past years. But I want to invite my colleague Stefan to talk about his work as a peer worker after my short presentation. I think this is more valuable for you than the theoretical approach and the historic work we did in the past years. So no, it's not working, doesn't move. Okay, stop
just
share.
Click on the, if you click on the presentation.
Yeah.
Nothing moves.
Maybe like this. Okay, yeah.
Perfect.
So to start with, Free Clinic Antwerp is an organization that has a long history working with people who use drugs, and we have a long history in working with hepatitis C. As you see, in 1997, we had a first conference on hepatitis C and drug use. This was really the first conference on hepatitis C in Belgium. And we started collecting data from the early 2000s, and we moved on with different people working in this field. And one of the most inspiring people was Professor Dr. Kati Matei, who did a lot of work in creating a good management plan on hepatitis C, and we still are working on or building further on the work she did in the early 2000s. So our first project really on hepatitis C and peer support was in 2009, where we noticed that there was a need for more support, and we decided to work with peers on that. Unfortunately, it had to stop due to funding, but we never left the idea of working on hepatitis C. So the first start in 2009 was in the interferon era. So remember this was a really, really hard time for people that had the treatment for hepatitis C. And as we work with people in very difficult situations and not with a large social network, there was really a need for extra support. And that's why we ended up with working with peers who in this interferon era did many tasks in supporting people, but was really, really focused more on doing visits, accompanying people to the doctor, doing some errands because people were able to do this themselves. And then after the start, we needed to stop due to funding or lack of funding, and we had the chance to restart in 2015. And Stefan was first a client at Free Clinic, and he also did the treatment on hepatitis C with success, I can say. And at the restart, we were very fortunate to have him as a volunteer in 2015, and I think half a year later we could give him a contract as a direct colleague of us in the C-Buddy project. But by then the focus was changed. We had the DAA, so treatment was different, and the needs were also different. And so there was a shift of the focus on the support. And together with a hepatitis C nurse and now 2 peers who are really direct colleagues and some volunteers who are working in the C-Buddy project, we can support people in every step of the care cascade. So it's very holistic. We work not only on the virus, but on very different life issues. In the C-Buddy project, there is a very important role for the hepatitis C nurse, but it's on the same level as the peers. Peers, nurses, myself have the same voice in our project. So not all decisions are made by the nurse or by me. Peers are on the same level in our project. And what is the Antwerp model? So as you see, we have Free Clinic as a low threshold center. They can do the pre-treatment, the counseling, the screening, and the referral. And they have OAT, they have needle exchange. So we can support people on different levels at Free Clinic. The same is in the needle exchange, where we do lots of prevention, harm reduction, provision of safe injecting materials and techniques. And the third part of the puzzle was our local hospital with a local hepatologist who is very open-minded and very willing to treat people who use drugs. And we call him Dr. B. He's a very streetwise hepatologist. And he gives us an open counseling moment where we do not need to make appointments, where we can bring people without an appointment to his counseling, and there is screening and sometimes if needed and if wanted, people can start with treatment in a few days, but Stefan will talk about that in a few minutes. And then the missing puzzle in the whole care cascade were the C-buddies, was peer support. We need the peers to be able to connect with new patients. And one of the important roles Stefan will talk about is guiding the patients or clients through the whole process in the care cascade. And they can make appointments, they remind clients about their appointments, they navigate the clients through the hospital, enhance the treatment uptake and compliance. And sometimes it's really necessary to translate the medical terms sometimes doctors and healthcare providers give, so they can talk about it in a normal language. We are working in this model for a few years now, since 2015. And the key factors of this model is that we are as flexible as possible, and we can change the model at any time for any client. Every member of our team is as important as the hepatologist or the doctor or the nurse or the peer is. So we also are involved in the treatment, and the hepatologist sometimes asks for advice to the team, same to the peers as to the nurses. And I'm very proud to say that every member of the team is very dedicated to work in this project. We need to have a good communication between patients and ourselves. And I think one of the strengths really is that we have colleagues who are also peers, and that they can give the extra thing we need in working with the clients. As I said earlier, it's a very holistic approach. Sometimes it's really focused on the virus themselves, but the team is working on different levels in the life. So they work on finances, they work on other issues, administration, housing. You can't imagine what they all do. And one of the other strengths is they are very mobile. So it's really outreach work. We try to connect with people in the drug scene. We go on house visits. And Stefan will also talk about that sometimes they deliver day by day the medication if needed. So this was a little bit the history and the model. I'm open for questions after this talk, but I really want to give the floor to Stefan to talk about what they do, what the role is of the peers, and of course the role of the nurse is quite medical, but they both are also working in the whole holistic approach. So Stefan, please talk about the work you do.
Okay. Hello. Does everyone see me and hearing? Okay.
Yes.
So yeah, I'm a part of the C-body team. I'm also like an experienced worker. I was Tessa said it in the beginning. I was client in preclinic. I was and then I was a volunteer, and then I became a worker. My job is to make a good connection with the clients, with the doctor. For example, part of my job is to make the schedule for the client, for example, to meet the client, to talk about, for example, to talk about the hepatitis A, the problems that he has. We're talking about stigma, about I make like a assessment of all the problems that they have, social problems, physical problems, addiction, and then I have like a small information, like a small profile that I can create, and then I give him an appointment. I give an appointment with the doctor. There I go. I also help the client to go together. I go together with him to the doctor. I have the freedom to make my own appointments, because every one time in the week on Wednesday we have our own block from 12:30 till 2:30, and then I can give the appointments myself to the people who are coming, and then I just send an email to Dr. Bourgeois, those people are gonna come, and then he knows who are coming. So that's how I make the appointments, and then I'm always there in the hospital. I bring the people. Sometimes I go take them from their house, and some people, if they're too sick or if they can't walk, sometimes we hire a taxi. So I bring them with a taxi, or we just take we take the bus or the tram together, and or someone from my team is already there in the hospital. We are now a little bit larger team than we were before, so there is always someone waiting there at the reception. So we also, when we're there, we receive the people at the reception. We help them to navigate in the hospital, because now they moved from the old hospital. We moved to a new hospital, and now the new hospital is like it's a lot bigger and it's a lot more complicated to navigate in it. The old one was difficult, but the new one is even a lot more difficult for the clients. For us, it's very easy because we know everything, but for people who come for the first time, it's very difficult, and it's also like if they're not sober, sometimes it's also very annoying. They don't want to wait. It's like it's a problem. It's a problem for them to go to a reception, then to take the elevator, then to go to sit in the waiting room. So we have to be with them, like to make everything to fall without a problem. And then we're going. So we're together with the clients when they enter the Dr. Bourgeois at his cabinet, and there we can talk about how we do an approach to the treatment. Dr. Bourgeois he's doing normally. He has to do at least 2 appointments before he starts the treatment. He needs to take one time. He needs to take blood, and then also he do an echo, so to see the level of the genotype of the infected person, and then he knows which kind of medication, which kind of treatment he has to give. Then normally we also do delivering. We deliver the medication to the clients. It's some people are very very correct. We only see them one time per week. They come to free clinic and they get their box to us, and then they know how to take their medication. But some people are not so correct. Like they take alcohol with the treatment sometimes, or drugs, and they forget when they have to take it. So yeah, we have to call to remind them, or we have to go to visit them. We have to bring the medication. The other things that we do is we help them in their houses, like to improve their housing conditions. If there is for example a lot of garbage, or if they don't have washing machine, or if they don't have a fridge, or if they need a television, or if they need an appointment with the social services, we do all those things for them, so they can feel like more not so isolated, not so stigmatized. They know that there is someone who's watching out for them, and can help them during the treatment, and that this way it goes better. We're also doing we're collecting information. We're doing like collecting all the information from. We make a database with the name of the clients, and we store all the data there. For example, who has been treated when did they get their medication, did they get their SVR, when is their SVR scheduled. There is also information about using drugs, and we make the files that we conducted. It's very nice. It's evaluated through the years. We went through a few models. Now the last model is It's very well made. It's very professional. It has a lot of information inside. You can ask me some questions also, because I'm a little bit nervous. I had a busy day today. You know, we started treatment with the client, and he was very motivated. And the last 2 weeks he was, you know, I was calling him every week, two times or 3 times per week, and he was always saying, "Ah, yeah, Stefan, the treatment is going very well. I take my medication. I even write in a letter in a bookske, what time I take my medication." And then this Monday I see him in front of free clinic, and he say, "Yeah, but I'm gonna stop with the treatment." So we had to go, and he lives very far from us from here. So we went together with my colleague, with Carmen. We went to his house this morning. We tried to convince him again, like to do another effort, like to say, why do you want to stop the treatment, and can we do something to help you? But the man, he was really like really adamant. He didn't want to do the treatment, so we had to take all the boxes back with all the medication. I was a little bit disappointed. I was a little bit annoyed and disappointed. Like I made a lot of effort. I went like the last 2 weeks to his house every week, and I was calling him, and I was like so positive. I was thinking that I'm doing something and that is gonna be success. And today I was a little bit disappointed. It didn't work out so good, but it's not the end of the world. We still keep a contact with the person, and we were always there to help, and in time we can make another try to offer the medication.
Stefan, is it correct
Yeah.
that we can say that one of the important things you do is motivating people and never give up?
Yeah, that's true. Yeah, we're motivating them. We're motivating them because you know how it is. There's a lot of stigma and a lot of urban myths, and people in the beginning they don't know much about hepatitis. They only know the bad things that they heard from mouth to mouth from people. So our role is very important to give proper information and to motivate the people.
Yeah. And can you say what the extra value is from your own experience, that you did the treatment yourself and that you were once a client in free clinic? What is the extra value as a peer working in this one?
Well, the extra value is that I have been in the shoes of the clients, and I know how they feel, and I know how everything works, and I have better idea than the people who just do that for work and for a job. I feel a little bit closer to the people, and I have experience. Like it gives me experience, and it's easier to make contact with people and to communicate with them. We're on the same level.
Thank you. I think maybe it's time for questions.
Yes.
Yeah, you can ask some questions.
Both. Yes, so please, if you have thank you, Stefan, thank you, Tessa. Please, if you have a question, raise your hand via the button or on the screen. We have like minutes for the questions. So, okay, so no question. So I have question.
Okay.
To you, Stefan. How do you I can imagine it's a lot of work, to, even if I imagine myself to keep my diary, and schedules and everything and appointments and, meetings. How do you handle this, and how many clients do you have, like, in care?
Well, until I handle it well. I have my time. I just divide my time. I have my box, and I do I compartmentalize the different jobs and the different tasks, and I just take my time for it. I normally I need 1 hour. I need 1 hour to make the schedule for the weekly schedule for the doctor, and also 1 or 2 hours to reach all the people who have to come. I normally call them on the phone, but we also go and look for them. And before the pandemic, we had more clients. We had like 6 people. We had like from 4 to 6 people per block. But now the last 1 year we have less people. We have like with 2 or 3 people per walk that come per week. And at the time of pandemic it was also busy. Then we had also like 4 or 5 people per walk. We didn't stop working during the pandemic, but it's difficult. It's difficult to, just to reach the people. Well, that's the most difficult part, because many of them, they say, yeah, we're gonna come, and they make an appointment, and then when the time of the appointment comes, they're not there. Right? So sometimes it's a little bit disappointing, but we learn how to work through it.
Yeah, thank you very much.
And in total we have many people. I have a work list. I just have to find it.
I think in 1 year about 140 people are supported in one way or the other by the team, and it's really a small team. So
yeah, thank you. And we have a question here. What is the success rate of the project?
The success rate? Well, we're working. We're very lucky that we're working with a very good doctor. We're working also our colleagues, our nurses, our doctors in free clinic, our social workers. They're all very competent people, and they're very open-minded. And everyone they don't stigmatize, they don't judge people. So it's going very easy. The work is going very smooth. I'm very grateful for all my colleagues that I have.
Okay, thank you very much. Thank you, Tessa. Thank you, Stefan, for your very nice and interesting presentation. And now if we have a time, we can get back to questions if there will be more at the end of the webinar. But now I would like to move to second presentation, which is mine. And I'm Barbara Janíková, and I work for the Společnost Podané ruce, which is the NGO based in Brno and working in several regions in Czech Republic. And I'm working on project of HCV testing and linkage to care. And I'm in the harm reduction field for more than 20 years and doing more projects around harm reduction, DCR, developing new services, and so on. So that's shortly about me. And now I'll try to share the presentation. And I think I will be also following the topics and of colleagues from Belgium. So I think at the end we will have like really 4 different countries and different cities, but we also probably find some, common things and links in our work. So my presentation's title is Multi-Agency Cooperation and In-House DAA Treatment. And first of all, I would introduce our NGO. It started in late 80s as a group of peers who were like providing services during the communist time to other peers. But it got official after the revolution in 89. The NGO sector started the development, and officially the NGO started in 1991. And we have over 50 programs and 300 staff members mainly in 3 regions of the Czech Republic, and you can see it on the map. So it's mainly the east part of the Czech Republic, and the base is in Brno, which is the second largest city in the Czech Republic. We do the point of care testing and screening on HIV, HCV, HBV, and syphilis in 25 centers of the services. Mainly, these are harm reduction services, but also we test in therapeutic community, in after prison release service, methadone treatment centers, and so on. So not only needle exchange programs. We have one specific project for HCV testing, which was like also boosting the overall testing for other diseases in last 5 years. And we have more than 3,000 HCV tests per year. And the overall seroprevalence is decreasing as we test each year for several years already, like 5 years within this like age-specific HCV project. But there have been like in whole Czech Republic, the screening and testing was like increasing since 2000. So we are now on the seroprevalence slightly above 13% within our organization. And the second part, so that was the NGO, and now I would like to introduce the Podané ruce clinic, which is the healthcare unit under the Podané ruce umbrella. So this is the specific like healthcare facility with several centers, and as it can be NGO, so it's like private healthcare unit, and within this unit we have primary care centers, psychiatric care centers, ketamine-assisted treatment, and also infectology center with the DAA treatment center, which is quite specific because in our country the treatment is for the Hep C is possible only in DAA center, so it can't be within the primary care or other healthcare provider. So it has to be DAA center, which is established, and it has to have the permission for doing that. And usually it's within the hospital. So this is our DAA center is the second one, which is outside of the hospital for the whole country. And we are quite happy about it because it brings the care closer to people. So I would move to introduce the Brno city, which is the second largest city in our country, because as I shared at the beginning, we work within like more regions, but I would like to focus more on Brno situation, which is more clear to share with you within this presentation. So in Brno, we have more than 400,000 inhabitants. The estimation of people who use drugs is more than 2,000, and there is a socially excluded community and Roma community. The HCV seroprevalence within this specific community is around 50%, and nationally it's 37%. So you see that it's above the national average. In this specific area, it's heroin and methamphetamine used mainly. And we have 2 drop-in centers and 1 outreach program and mobile DCR since 2023, which is operating in this excluded area. I would like to show you a few pictures. This is the DCR and outreach program van. So they are operating together in that area. So there are 2 cars, one for the DCR and one for the needle exchange, and screening testing from capillary blood, so people can get the services together at one spot. Here you can see the infectology and primary care facility within the methadone program. So that's newly opened only for 4 or like 2 afternoons within the week. So that's specific project. And it's also, again, within this excluded area that people can reach this facility where is a doctor and nurse very easily and get into the contact. And the doctors who are serving the care here are also infectologists. So the client who is coming here can solve any health issue and also hepatitis C or other infectious issues, and can be offered PAA here. And this is the infectology and primary care facility, which is a little bit further from the center and from the excluded area. So people can visit this facility or the closer one in the city center, and will be served. So what is our system or our model for the screening and linkage to care? It's like cooperation between different services, as we are quite big organization, and we are like linking the services via infectology nurse who is visiting different harm reduction or other services and offering the clients blood sample collection, care management, and also the DAA management. So also people can, via this infectology nurse, can obtain the DAAs, the treatment. And that is cooperating with the harm reduction service staff that are providing the rapid tests on the spot, and they are referring the clients to the nurse, or the nurse immediately work with the client who would like to have the blood sample at the spot. So the nurse is coming to the outreach, to the van to collect the blood, to the drop-in center, to the methadone program, and is assisting the clients there. And also we have the peer support group. So this is the group which was established within the European project, I think like 7 years ago. And the peers are doing several tasks within the organization. It's like needle collection in public space, providing support in the low threshold center for alcohol users, and so on. So there are many tasks, and also one of the peer group is supporting the nurse and the harm reduction programs and assisting clients to the doctor's office, or assisting clients with providing them like with the food packages or clothes packages. So basically like trying to find a solution for each client. So something like what you, Stefan, shared, also like providing, the communication chat with people and assisting them so they can go through the treatment and get their well-being better overall. And under this line, you see the healthcare clinic I was sharing the pictures of, and the low threshold health center based in the methadone program. So these two are like fixed site, and the nurse is circulating between the centers that are providing service to the clients, and it's supported with the peer Yeah. So that's like the system that it's working for now, and we are quite happy for it. That there is like one link in between the services, and also people can, like leave their medication in addictology service, can pick up, every day their medicine, and after some communication with the nurse. So there is a lot of communication between the services and between the nurse and the healthcare clinic and the doctor and the specialist. So what we can sum up, that via this model we brought, like, because before clients had to go to the hospital, so now the care is coming to them, to the services, and the treatment to the services. So it's not that big gap for them, not that big threshold for them to go to the hospital. So it's much more closer to people who use drugs now. I didn't say that we started with the DAA center only 1 year ago, and we have more than 20 HCV treatments successfully started and successfully finished in this first year. And also, as the DAA center is also other infections disease center and the primary care, people can get more of the support, and they can find the care they need for other issues, which is also very valuable. Most of them, like majority of them, they don't have their own GP to go to with other issues. So that's pretty much from me for now. So I'm open to questions. Do you have any?
I have a question. Yes, I have a question.
Yes, please.
That's very impressive with the gypsies, that you have so many gypsies that take drugs. It must be very difficult. Do they all come to the clinic there?
They are coming to the harm reduction programs, such a outreach in that specific area, and to the DCR, which started only a year ago as well. So we are trying to bring more services to that area and let people, to come in and use the services. And as you say, yeah, it's hard because, that there are different, different communication, different values, and also
different culture. It's completely different culture.
Yeah,
we don't have that here. Yeah, we don't have that here. Yeah.
Yeah.
And who's paying for their methadone? Who's paying for their methadone?
Who's paying? The methadone is paid by, like, this is the system for the whole country, that it's paid by the Ministry of Health. There is, like, program for it, and they don't have to pay. Clients are not paying for their methadone.
Oh, that's good. That's good.
Yeah, so for all clients in my country, methadone is for free.
And how long is the hepatitis treatment? How long is the treatment for hepatitis?
It's like standard treatment.
2 months. 2 months.
Yes,
is it 2 months?
Yes.
Yeah. Okay.
Yeah. So that's like, there is no more of the interferon. Yeah, it's like everything, all the treatment now is with the DAAs.
And you said in the beginning that you started during the communism, before the communism fell.
The NGO, like the group of peers, was like providing care for each other and for others from the community, because we had the drug use like during the communism.
We really?
had methamphetamine, we had codeine solution, like based codeine, which was called brown because of the color. So these were like two mainly injected substances, methamphetamine and called this brown, and both were like homemade in the kitchen.
Yeah.
So since then, you know, this group after revolution like started officially the NGO.
It's very interesting. Very interesting. Very good. Very good.
I see a question from Nadia.
Question from Nadia.
Yes.
Yes.
No, just I have like a question, like curiosity. You say at the beginning that in your region or in Borno, the HCV prevalence is 50%, while in the country it's like around 37%. So just, I mean, why is that, I mean, so bigger the prevalence in your region? Do you know?
Yeah, that's the, it's not the whole Brno, not the whole city, but in that excluded, socially excluded area. Yeah, there is a lot of like drug use and injecting in a place. So this is basically why, you know, because it's like one district of the city with a lot of use. And it's specifically Roma community there. Yeah, so that's for this area. Yeah, so that is higher than in the whole country average.
So it's mainly due to drug use.
Yes, yes.
Okay.
Yeah, and yeah, intravenous drug use. Yeah.
I have one more question.
Okay, and then we will move. Yeah, because
I just want to ask about the hepatitis treatment. Is it paid from the medical insurance, also from the government?
Yes, it's like it's paid by the health insurance, so the client is not paying anything.
Oh, that's good.
Yeah.
Okay.
So because we are here in the country, everybody is insured by the law. Once you are born, you are insured, and then you have to pay your health insurance. But even if you are not paying, you are still insured. So you have your insurance secured, and you can, you know, have the care. Yeah,
that's
and
nice.
the other thing is what you own to the company if you don't pay, but you are still insured.
Okay, thank you.
Yeah.
Thank you.
Thank you. Okay, so we will move to the third presentation for now, and I would like to ask Jukka Koskelo from Finland to join us here, and I will share the presentation for you, but I will first introduce you. So Jukka Koskelo is a Research and Development Director at the A-Clinic Foundation in Helsinki. And Jukka has a track record of completing national and international projects on infection disease-related problems. He's researching especially HCV and people how are injecting performance and image-enhancing drugs. And he's also a steering committee member of the Finnish Healthcare Services for Prisoners. So I will share your presentation for you.
Thank you. Thank you. And meanwhile, I'm just going to ask, shall I squeeze a little bit my presentation? Because, well, we are...
I think we are still fine.
We are fine.
Yeah. Okay. And it's here. Yeah, sorry, I need to close mine first. Okay, just a minute. Okay, it's coming. So no, it's mine again, sorry. I was closing it, but it didn't close fully. Sorry, Jukka. Once again. And it should be fine now. Okay. So the floor is
now
yours.
okay. Yes, and of course I just included animation here. So Bara, you have a really difficult task to press the next buttons. So
Yes.
go for it. So I'm going to start about, well, of course, a short introduction. So our foundation, oh, it's going so fast. Yeah, we were founded almost 70 years ago. So we were founded, to provide treatment for the alcohol related problems. Well, in 1955. So now we are more focused on the prevention and harm reduction work of different addictions. So that's in general. But well, anyway, we are a non-profit and non-governmental organization, mostly funded by our governmental funding, applying that. But well, we also have the funding from many different sources. Okay. Oh, yes. Okay. Like I say, we just prevent and reduce different harmful impacts of the substance use, well, and addictions. And when we are talking about the substances, we are talking about the alcohol, drugs, and like Barbara was saying, performance and image enhancing drugs, meaning doping substances like anabolic steroids and testosterone and so on. And of course, while we have different projects to support people who just, for example, don't have housing and other kind of projects as well. But well, we also have quite a good number and reaching millions of people through our digital services. And we also do the addiction research. And well, the size of our foundation, well, we have at the moment around 50 people working. And like I said, what kind of units we have? So like I said, we have 4 different, just keep on rolling. So I just can speak the entire slide. Yeah, thank you. So 4 different projects with the digital services. So that means that people can find help and advice for their problem completely free from our digital services. So they don't have to put any names. They have to, so it's completely anonymous what they are just using and asking help for their problems or the problems that they having in their family. So, and we have, okay, I'm not going to go through all of our 11 different research and development projects because, well, we're going to be otherwise here till the Christmas. So that's going to be another presentation. But the main point of this presentation, I'm just going to introduce our outreach work, what we are doing. Our social street work unit has the 7 different projects. So there's one street clinic, which I'm going to talk about in the next slide. But we have also the voluntary, oh, don't, just go back. Yeah. No, you're going forward. So, oh, how to go back? Okay. Now, perfect. So voluntary work. And I think we have more than, I think, close to 300 volunteers in our lists. So what they are doing, they're just going the streets and clean the environment, for example, provide food and clean the surroundings from the needles and syringes and many kind of that kind of work. And so we have the social inclusion and peer support, like a cafe, which is like open 3 days in a work. But also, like I said, we are also having the one project providing homes and supporting the housing, the people who don't have the home, and when they are just using different kind of substances. And of course, we have other projects as well. So we just providing the, well, for example, neighborhood work, so which I don't know how to write in English, so I just know this now. Don't mind about that one. So, but well, the main thing what we are doing is the street clinics, where we're providing hepatitis C and HIV testing. And it's, well, the Finland is a big country. We have big distances, so we are doing the street clinic work in the 3 different cities. And now the next slide. Thank you. Perfect. Now I'm talking about, this slide is in Finnish, so it's from our national records, HCV prevalence in Finland. So it's around 1,200. So, and the gray is men, and women, and green is men. So it has been quite stable for many years, like 10 years at the moment. And the next slide. Now we go into the social street work. Okay, now we're going to stop here. So in every city, well, in 3 cities, we have a pair. It's the nurse and the social worker. They just go into the streets. They have a car. It's not the mobile one. So it's a normal rental car where they're just going to different places and finding and doing the outreach work and trying to find people who are injecting drugs. Yeah, and one of their work, like Tessa was saying nicely, that okay, you are doing holistic work. So that's what we are doing as well. They are just supporting people to go to the test services, go into the healthcare, go helping with the housing, and well, in the small scale, doing well, also treating. Like if you have some kind of infections in a small scale, and just okay, giving all kind of help what they are just gonna need, and going with these people to the different places, to the authorities, to the hospitals, and so on. And okay, we have like 6 people all together in our foundation doing this kind of work. So the test number is not the huge ones at the moment. Okay. But well, anyway, it's better than nothing. But well, it's quite interesting because well, we have the testing prevalence in the different cities is completely different. We have one city called in up northern part of Finland. So, and it's difficult to find these people from there. And like I was talking to these people today, and it has been a crazy snowstorm here in Finland. So people are still going and do the outreach work. They were completely frozen there. Wet and snow was coming from the sky. So they were still on so dedicated to their work. So they were just doing the outreach work, even that the crazy weather was we have here today. And of course, well, these nurse and social worker, they are both doing the rapid testing. Yep. And also, well, of course, well, just providing and confirming the infection and going to them. Yep. Let's start there. Go into the health clinics or the hospital or health centers to confirm the infection. But well, the interesting part is that with the prevalence of the hepatitis C, so 50% of the positive tests, they're not gonna see them again. They are unreachable. So, and half of the people, so well, in our case, well, like today, well, this year we are talking about the 10 people. So they are just basically losing the 10 people. They are not willing to go to the treatment, or they are unreachable. Okay, and the tricky part of the testing is that, okay, Finnish Institute of Health and Welfare just is providing for the nurses and the social workers mandatory education before they can do the testing. And with the social workers, you must have a special permission by the medical director of the NGO or the institute that the social worker can do the tests as well. So, and they have quality controls 4 times in the year for the testing. So it's quite a long thing what they have to do. Yeah, just go through whole slide, so it's much more easier to do this. Okay, thank you. Okay, and we don't have any community-based or community-led organizations in Finland at the moment. We used to have. And this is the main point, especially from our side of this BOOST project, that we are getting information, we are sharing the knowledge, we are learning from the other partners and other lighthouses, how we can build up community-based and community-led organization again to Finland. So, like I said, we don't have a mobile van, we don't have a drug consent rooms, and we are lack of funding, well, like in many countries as well. And also because our work, our NGO, we cannot duplicate the work that the public health services should provide, like testing. So it should be offered by the public services in our country. And yeah, and also the treatment should be carried. That's our national recommendation, mainly in the places where infections is detected. So that's going to be like really challenging for us, because well, I know in a couple of health advice centers where people are just well, they are giving needles and syringes, so they don't have enough staff to provide testing. So that's a tricky situation at the moment, but okay, it is what it is, and we just going to build up the best possible services for people who are using and injecting different kind of drugs. Okay, let's go to the next slide. Whoa, okay, oh, that was the thank you slide already. Yeah, I think that was really shortly what we are dealing at the moment in Finland and in our foundation.
Thank you very much, Jukka, and sorry for my clumsy
No problem. Yeah.
So is it okay if I stop sharing presentation? Thank you.
Yep.
And let's open the floor for the questions.
And if you have questions, just ask easy questions only.
Okay, we might try. So you can even, post the question to the chat or raise your hand. or pressing the button with the hand. So maybe I would like to ask, as you said, the lack of the community-based organizations. So like what is in this field like happening, or like if your organization is like, making some steps, or because, the situation doesn't look
Yeah, it is because well, it was a couple of years ago we had this community-led organization. It was existing, and we were just working closely with them in many different fields, and well, we had many projects. But well, I don't know what was the reason. Well, it is not existing anymore. So, and there haven't been any people who just would like to start everything from the beginning, from the start. The community-led organization, when you are just creating an organization, it's required some kind of work, and also it's challenging, and but well, we are making our best and supporting these people and organizations for the future, and finding them and just to build up. So it's challenging. It's really challenging at the moment. So
okay.
And I'm so jealous what you have done in other lighthouses, like the work. Like well, maybe someday we also have that kind of work.
I'm sure. I'm sure we all. And thank you for your hard work, and for your organization's effort to go on. And if it's okay, please, I would leave this question at the end, so we can. There is one more question in the chat, but let's leave it for the end, as if we have time. Or Jukka, if you would like to respond to the question to the chat, please. And because of the time, we would move to the next presentation. Is that okay?
Yep, yeah, I'm responding to the chat, yes.
Okay, thank you very much. And I would like to invite Nadia to share her presentation. Nadia Gasbarini is I will introduce you meanwhile. Nadia Gasbarini is a program manager at Villa Maraini Foundation in Rome, Italy. And Nadia is coordinating international projects and activities on substance abuse prevention, treatment, and care. She has been working for more than 20 years with COAs and international organizations such as UNODC and OSC. She's the co-author of several publications on drug abuse-related programs and an expert trainer on harm reduction and humanitarian drug policy. Please, Nadia, the floor is yours. Welcome.
Okay. Thank you, Barbara, for the introduction. So I don't have anything to add. So just Nadia Gasbarini from Villa Maraini Foundation Rome. My presentation will focus on the activity that we do, the outreach testing for infectious disease among key population that we provide through our mobile unit. So just few words about Villa Maraini Foundation, who we are. So also we are very quite old organization. It was founded in 1976 as a service of the Italian Red Cross, and now is one of the main center for the care and treatment of substance abuse in Italy. So during more than 40 years of activity, we have enlarged a lot our services. So now we provide a different kind of program for people who use drugs, including alcohol, and also other vulnerable groups. So we have low threshold services where we provide mainly harm reduction activities. So the street unit, the emergency unit for overdose intervention, the drop-in center, night shelter, and activity in prison. Then we have high threshold services for people who want to do a long-term treatment program. So we want to stop using drugs. So we have therapeutic communities. We have an alternative center to detention, which is for people who are in alternative measure to incarceration. And then we have an outpatient program. So for people who cannot have a fixed job or other issue, they cannot just leave anything and spend time in a therapeutic community, so they can do this outpatient treatment program. And then we have also medical services. So we have a clinic center where we provide oral pharmacological therapies, mainly methadone, and a unit for infectious disease, mainly HIV and hepatitis C. So our center is open 24 hours every day of the year, and we see around 600 clients every day. So regarding HIV and hepatitis C, we try to provide almost, the full package of services as recommended by WHO and all the main organizations. So through our harm reduction services, we do outreach, education, counseling on safer injection and risk reduction, access to sterile syringes, needles, and other equipment. Then through our clinic center, we provide methadone opioid substitution therapy. We have access to special primary care. Of course, we provide testing. I will talk about this now, and linkage to care for HIV and hepatitis C. So for all these kind of activities related to infectious disease, we have a specific unit in our organization. The goal is, of course, the prevention of HIV and hepatitis C and other infectious disease among vulnerable groups. So we focus specifically on people who are most marginalized, out of care, so that they don't have any kind of link with the public healthcare system. So this includes not only people who inject drugs, but also sex workers, LGBT community, homeless, and migrants. The service that we provide through the unit include, of course, screening and testing, both on site, so in our premises, that on the street, through our mobile unit. We do counseling, linkage to care, and we provide also psychological support to people living with HIV and hepatitis C and their families, and peer-to-peer education. So among our staff, we have a social worker who are former drug users, so people with an experience of drug use, and also or living with HIV and hepatitis C. So key population who we test mainly, as I said, we focus on the groups that are called most at risk or out of cares. so group of people who for their behavior, living lifestyles or social factors are out of the health care system or are, I mean, hard to reach, as normally said, so it's difficult to be reached by the public health system because they are vulnerable, marginalized, stigmatized. So we started our activity on like screening and testing of HIV and hepatitis C with people who use drugs, because this is our main target group. But then we have enlarged our testing activity to other vulnerable groups, so sex workers, LGBT communities, homeless, migrant. And I mean, we are able to do this because we have our mobile unit, a camper, and so with this mobile unit we are able to going in the street in different location of the city and reaching different key population. So where we test, exactly what I'm saying, we test where they are, so in the street or in the place where we know that we can find these groups, because I mean, the main objectives of this like activity is to decentralize services, so try to increase access to screening and testing in non-medical setting, so not like in the hospital, but outside in outreach setting or in place where maybe normally these services are not provided, but where it's much easier to reach and get in contact to the people who need testing and screening. So for people who inject drugs, using drugs, we provide the testing in harm reduction services, so or in our outreach mobile unit, where we provide needle and syringe program and other harm reduction activities, or in our clinic center, where we provide methadone therapy, or in the drop-in and in our night shelter. For sex workers, we go on the street where they are. So there are various different locations in Rome where we know that there are, I mean, it's much easier to find sex workers there, and so we go with a mobile unit in these places. For LGBT community, we go in nightclubs, disco, places which, I mean, are mostly frequented by LGBT communities. For homeless, the same. We go in the street or in a night shelters managed by other organizations in the city. And in the last years, we are providing testing also to migrants, so migrant, like different migrant communities in Rome. As you know, Rome has all the big cities. Now there are some area which are like where the majority of people living there are migrants, migrant community. And so we when we receive, like we started receiving a specific request from the municipality and from the same community members to have the possibility to receive the testing for infectious disease. And so we started this activity, and we are now, I mean, doing not regularly, but quite like often. So how this is like the typical, let's say, like methodology used. So let's say the HIV and hepatitis C care cascade. So of course the testing is offered on a voluntary basis with the consent of the people. Before we used to ask people to sign as a written consent. Now we are not doing this anymore, but of course the test is voluntary with the consent of the people and free of charge. Then people who accept to get tested receive a pre-counseling where we explain how the test will be done, the benefit also, of getting tested, and we do also together a questionnaire to collect some information about risk behaviors for infectious disease. So asking people if they have never been tested, if they have risk behavior in terms of sexual intercourse or drug use. So we have our own data collection tool, but we are going to start now using the COBATEST questionnaire, which is used to many organizations now in Europe. Then we provide a test, which is rapid testing on blood for HIV and hepatitis C, and of course post-counseling. In case of a preliminary positive result, we refer people to treatment to some specific hospital for infectious disease in Rome, and we have an agreement with 3 of the main clinic for infectious disease in Rome. And according to or thanks to this agreement, we have like let's say a fast track. So people who are referred to this hospital by our mobile team have like a fast track, so they are immediately taken into care. So they at the same day they can receive the confirmatory testing and all the other analysis required to confirm the diagnosis, and they are immediately linked to treatment, so they can start a treatment if needed. This is, very important, because we also had in the previous years a problem, let's say, with linkage to care and follow-up. So we always refer people to the hospital, but then it was difficult to follow up with clients and to monitor adherence to treatment. In this way, through this collaboration, now much closer, we are able to also to follow up with people and to monitor their adherence to treatment. Our staff is written here, is composed by when we provide the testing. Normally we have a doctor, a counselor, and a social worker. The social worker is also has the authorization to provide testing, because in Italy there are some, we are our organization is part of the National Committee on HIV and other infectious disease of the Ministry of Health. And so there are all the organizations which are members of this committee have got the authorization from the Ministry of Health to provide rapid testing, to authorize also social workers, so non-medical staff, to provide rapid testing. So our social worker, of course, who are trained for this, can provide the test on the street. Then this is some informative materials that we provide to when we decide to do some specific events for testing, because sometimes during the 1st of December or other important day, we organize like some testing activities in the street, not only for this key population, but also for the general population, let's say mainly focusing on young people, because now in Italy in the last years there is like an increase of HIV among young people, because I mean it's like something is young people really don't have at the moment so much information about this, because not in the school or not, I mean there are no like information around, so even if it seems like not strange after so many years, but we still receive a lot of call in our unit with question about route of transmission for HIV, for hepatitis C. So there is still a lot of need of educating people, specifically young people, about this infection. Just some data for the last 2 years. So last year we did 853 tests. See, the majority were in outreach through our mobile unit, more than 500. And in 2022, also we did through the outreach unit, we provided more than 800 tests. And here just some pictures about our mobile unit. So this one is the place where we normally provide harm reduction activities among people who use drugs. When we do the testing, we have another camper mobile unit for the provision of testing, and this here is for the needle syringe exchange program. Then this is among sex worker. This is with migrants. This is the close to the Colosseum. Is called the Gay Street because it's a place with a lot of nightclub, mostly frequented by the LGBT community. So we used to go there to provide also testing and screening with our mobile unit. That's all.
Thank you very much, Nadia, for your presentation and for the last picture of Colosseum. I saw the smiles, on people's face. Yeah, so you do a lot of work. So questions for Nadia? Again, you can write in the chat or raise the hand.
Nadia, how do you manage to work 24/7?
How we manage? Hardly we manage. But I need to say, the services which are open 24 hours are our clinic center for methadone administration and the emergency unit. So the other service, so the drop-in or the therapeutic community, they are open till like 7, 8 in the evening. But in any case, it's quite challenged because we have a lot of staff. In fact, we have more than 100 people working in our organization. because for in the clinic center, normally we have 2 medical doctors during the day and 1 social work, no, 2 medical doctors and 2 social workers during the day. And in the night we have 1 medical doctor and 2 social workers. So of course we need a lot of people, and that's why we have always problem with funding, financial troubles, no? As almost all the organizations.
Yeah, issue, right? Yeah, common for all of us. Yeah. Thank you, Nadia. Some more questions?
I was checking in the chat if there is something.
Yeah. Maybe I have one. If you do the mobile units street testing with different target populations, do you do it like regularly, or like it's just like from time to time you go somewhere, or you've got like regular, time and dates?
For people who use drug, we do regularly because our mobile unit goes in the street every day. So we do regularly, or in the street through the mobile unit, or in our clinic center. For the other key population, we organize specific day for this. So normally maybe during a month we can do like twice, because also this also like an extra work specifically for example, when we do the activity for sex workers, LGBT community, so in nightclubs, disco is during the night, so it's something that need to be organized like as extra activities, but normally let's say twice a month.
Yeah, thank you very much. Yeah, it's tricky to work in the night, night shift.
Yeah.
But then you have the nice Colosseum, with the lights. Okay,
and
thank
we
you
don't
very
have
much.
so many snow and cold as
yes, in Finland. Yeah, sure.
Our outreach workers are
not that challenging. Weather situations in Finland. Okay, so I don't see any other questions.
I just want to thank you so much for the presentations. Just for curiosity, is there any community-led organization in Italy? Maybe you mentioned it, but I had to leave for a few minutes. But is there community-led organizations?
Yes, there are community-led organizations in Italy. We have also ITAMPUD, which is the Italian network of people who use drug, linked to Eurompud. So yes, we have, but as I say, in our organization, we also work, with peers, even if there is this definition of peers. For peers, we mean people with lived experience of drug use, but mainly are people who are not using drug at the moment anymore, so let's say former drug user. But for all our harm reduction activities and outreach activity, we have a social worker, former drug user.
Thank you.
Okay, thank you very much. So we are coming to the close of this webinar. So thank you very much, all of you, for the presentations. I think we really have the common, strategies, and I think our goal of all of us is to really bring the care to the clients and really, bring it closer and use what we have and what kind of, tools we have to provide the services as best as we can. Even the resources might be limited, and I'm sure we will struggle with this one like for more years or decades, but never mind, even with what we have, we are doing great job, and I'm sure, the people can benefit from it. So thank you again. Thank you very much for your work, and good luck.